All right, welcome everyone to PC 731 QI session. And I'm glad to have you all here, and I'm excited to hear about your projects. So I wanted to start off by having everyone just present their project. I know you've presented it a couple of times already, but you haven't presented it to me. I don't know anything about it. So if you can start off by telling me where you are, what your project is, and then if you'll show me the PDSA ramp slides, I feel like that's a good place to start if you have those available. If you don't have them available right now, then you can just describe the project. You have about 10 minutes to do that, and then we'll talk through a little bit. So who would like to start?
I'll go.
All right, very good. And I'm actually going to set a timer. I know that seems silly, but would need it, so we'll see. All right, go ahead.
Okay, I'm going to screen share. All right, can y'all see my ramps?
Yes.
Can you see my ramp?
Yes.
Okay. All right, so my name is Janelle Becker, and my project is elevated BMI in primary care and addressing it. And I am in a primary care clinic at Fort Stewart, Georgia, at Wynn Army Community Hospital. And what I've done is an SBIRT project. So we screen everybody, all the adults, and adults with BMI of 25 or over gets a motivational interviewing questionnaire. And that tells the provider where they are in their readiness level to change. And then they address the issue that they're at the appointment for. And then at the very end of the appointment, they go ahead and discuss their BMI with them and do a brief intervention by giving them 2 handouts that help talk about lifestyle changes with diet and exercise. And that's basically my project in a nutshell. So here are my ramps right here, and you can see my ramp A as I did a big kickoff meeting, and that's where I had at least 2 providers there with support staff so that I could go over my project with them and go over the data with them. And then I started the following week, or I followed the next day, I started my project with the initial staff. So where I'm at in my project right now is, I guess let me just show you my ramp 2. So I did a pre-test and a post-test. And so then for the second cycle, I went ahead and did a post-test assessment based on the data that was collected during the first cycle. So it was geared toward what we were missing, where we were weak in our processes to be able to collect the data based on the evidence. And so I went ahead and did a post-test again for my second cycle based on that data. And I ended up adding the motivational interviewing score to my project because I was really surprised at how many people were very motivated to change. They want this. And so that kind of surprised me on how willing they were to make a small change. And I had to do a lot of just individual reinforcement with the staff, and with the process measures, I've had to get creative. In my cycle now, I ended up putting them into a drawing because one of my ramps in my process changes was actually collecting accurate height and weight measurements for a good BMI. And that was really, really difficult to get them to get an actual height and weight versus just somebody telling them I weigh this or I'm this tall. So I actually had to get creative, and I said, okay, for every actual height and weight, you're going to go into a drawing for a $25 gift card at the end of the 2 weeks. And this was only the first week in our third cycle. And it actually, we had it bumped way up. So that's just basically my project in a nutshell. I know that we're not going to be going over right now our graphs. Is that correct?
You know, there's only 3 of you, so it's really up to you. If you want to show your run charts, you're welcome to, and we still have plenty of time. So
Okay, well, I'll just go ahead and pull those up for you then real quick. And you can see my measurements. Let's see. So my ramp A was my in-service. And my goal was to have at least 90% of the staff score at least an 80% on their post-test. And I have reached that. My post-test did change from week to week, like I said, based on how we were doing from the data collecting, just making sure we were hitting every patient with a BMI of at least 25. So I'm really not sure where to go with this next week. And so this is something that I really wanted to ask, like how you guys were doing with team engagement and how I was going to be able to actually, because I've been using assessments. And so I don't know if I'm going to be able to use an assessment with my last one. I mean, they've kind of hit the goal now of having at least 90% of the staff score at least 80% on their assessments. And so I just wanted to get some ideas on how I could ramp this up for my last cycle.
That's a great question. Does anyone have any ideas about that? Can you tell us more about the assessment that you're doing?
Yeah, sure. I mean, so I did it based on our evidence-based guidelines of, what our goal of the BMI goal was, because we were missing many patients that had a BMI of 25, they would be like 25.8 or 26. And, so we've just missed some of those patients. And so I would base my assessments and they'd only be like 5 questions, very, brief. And, it would just be like, our goal for, the patient's BMI is, 25, 24, 23, so it's just basically multiple choice questions and just asking about the data and saying, we want to get an accurate height and an accurate weight at every visit, true or false. We want to, it's just based on my other charts. I can come back to this if that would be helpful as I go through my other charts so you can see the data that I'm collecting.
Was it different assessments each time or the same assessment?
It was the same type of material, but they were different, but focused on the material that we were not doing so well in.
Okay.
So that they could try and get just reinforcement.
Because I mean, if you were presenting new information each week, maybe it could even be some kind of review where this is overall, now that we're at the end, all the information you've been given and, assessing on all of the information.
Yeah. It wasn't new information, it was reinforcement. Do you want me to go ahead and just go through and then come back to this?
Yeah, let's go through and look at your other charts and then
Okay.
We'll see what ideas we come up with.
Okay. And so then another one of my measures was our weekly huddles, and there's only a team of 4 of us. And so the last huddle, one of us couldn't be there. So that's why it kind of dropped down. So we do pretty good with the huddles, but there's just this last one, the schedule was crazy. So I anticipate that being able to go back up. This was so I started calculating the motivational interviewing score averages so I could share with the team. And as you can see, the median average so that score right there basically says that 91%, the average of the patients that we've been seeing, 91% of them are wanting to make a change, like right now, ready, because it's a Likert score and it's a 0 to 10. And so that's on a 100% scale, 91%. That's for their average score of wanting to make a change out of 100, which I think is pretty amazing, but that people are that ready. So I started collecting that data so I could share with the provider so they could see the patients that are willing to they want this, they want to get information, they want to partner up with us to be able to help them make healthier lifestyle changes. And then that was just another score. That was the support, if they felt like they had support at home with their friends and family. So it's still pretty high. And then this was just the participation. The lower scores was just the staff was not giving them the handouts to patients with BMI of greater than 25. So I think we are back on track with that. And then my other ramp is just the distribution. As I said, I'm sorry, this one was the participation, and but the reason that they weren't participating is because staff was not giving it to them. And then the distribution was low also because staff wasn't giving it to them. But it looks like we are back on track with that as well. And then this is the actual BMI documentation. So my research shows that if you have BMI documented with a management plan and a goal, that can help make changes to lower BMI over time. So this was one of my tracking and one of the measures I'm trying to get the providers to do. And as you can see, we had a little bit of an issue, but it's way up now. So I'm happy about that. So that's exciting. And then this was at the actual height and weight. We've kind of been all over the board here, but this was another, we were just trying to make sure we captured the accurate height and weight measurement so that we could get a good BMI on our patients. And then this was coming up with an appropriate management plan for our patients with a BMI of 25 or greater. And we're doing a lot better with that now as well. And this is a documented goal. So we're using a SMART measure to come up with a documented goal, a shared decision-making with the patient. And that has gotten better as well. It's increased. And my balancing measure is just a satisfaction survey at the end of the visit. And we had a real problem with just forgetting to give it to the patient because it's the end of the visit. You want to hurry up and get out of there. We would forget to give them their survey. And so we've really, I've made a highlighted chart basically that we've placed in every room to try and go through the 5 things that we were missing most regularly. And I think that's really helped for us to remember, oh yeah, survey, because it's just a really quick question for them. If they were satisfied with the visit and if they had any additional comments, they could leave that as well. So that is my project in a nutshell. And I'll go back to, does anybody have any questions about anything?
I think it sounds like a great project, and it must feel good to be seeing those numbers go up and seeing that improvement. I think measuring that motivational interviewing score and seeing how many patients are interested in change, about whether people would really continue this afterwards. And I think that is the best thing you've got to show the providers and show the clinic, like, it looks like patients really like this. It looks like people are really interested in change. I don't know if they'll continue without you, but it's a good start.
Yes. So that's why I started keeping track of it so I could show the providers, say, look at what our patients are wanting. Because it just surprised me how high the scores were. So I'm very pleased with that. But yeah, so my question is, since I've been using an assessment, I'm not sure what I can do for my next cycle to make that tweak of a change. I feel like another assessment really isn't necessary with how they've been doing these last 2 cycles, but I'm not sure how I can tweak it with keeping with my ramp.
I think that the way you've done your assessment sort of lends itself to just ramping up the assessment itself. So I think maybe more of a, like what was suggested before, a cumulative assessment, or even actually ramp up the assessment, ask harder questions.
Okay, so just do one more test and just kind of like a complete overview of the whole project.
And maybe honestly ask things that are a little bit, less obvious, or questions that you'd have to maybe have some familiarity with what actually works with weight loss, with all of those things. Maybe ask, is this a good goal? Or white.
I'm sorry, you broke up on me at the very end.
Oh, things that are less black and white. So maybe show an example. Oh, I'm freezing up on you guys. I can see it.
I'm going to go ahead and stop screen sharing. Is that okay?
Yes. So I'm lowering bandwidth. Are you able to see and hear me?
Yes.
Are you guys able to hear me?
Yes.
I just turned off my camera completely to make sure that I hear. So did you hear my comment about the assessment?
Yes, to make it more challenging.
Challenging and maybe even a little less obvious, maybe things that require more deep thinking, more assessment. So you could ask questions about SMART goals themselves. How do we help patients help lead them toward the kinds of goals that we know would be more successful, that kind of thing.
Okay. Yeah, I mean, because I did all of that at the beginning, so I could just kind of go back to my beginning kickoff meeting and pull information and data from that as well. So yeah, but as if you could see by my charts, I was really trying to pull the data to help them focus on remembering to give surveys out, remembering to hit the patients that had BMIs of at least 25, because we just weren't capturing all of them. So that's why I was continually hitting the same type of information, but just in a different way, trying to get them to remember to be able to collect that data.
Very good. Does anyone have any comments for Janelle?
Just a very good project.
Thank you. It's exciting to see, so especially those numbers going up at the end. I'm like, woohoo! So thank you.
Great work. All right. It's really fun. I mean, this whole course is really fun. It's really validating, but it's really fun to be at this point and starting to see these really great results. So great job.
Okay.
Okay, great.
I'm Amanda Oland. I am working out of a freestanding birth center in Baton Rouge, Louisiana, and implementing my project. It's ISBAR and CABC indicators of compliance for transfers from the birth center to the hospital setting. So let me pull my ramps up. Y'all can see my screen?
Yep.
Okay. To make them bigger. So cycle one, my ramp A was just a couple simulations and introduction of the two new tools that we'll be utilizing to help out with ISBAR and for the transfers. And then another aspect of the project is patient satisfaction, because currently, before the project, the birth center was not consistently sending out patient satisfaction surveys, and that's part of CABC accreditation as well. And so they were sending them out like every 6 months. They'd send out paper and pen surveys, and the rate of return was very, very low. So actually created a new patient satisfaction survey in SurveyMonkey, and initially sending it out within the first week of birth, and then they wanted me to send it out 2 weeks postpartum. So and then C&D as the ISBAR tool, which helps with communication whenever there's a transfer, and then the actual transfer tool, which actually helps to make sure that we're documenting all of those CABC indicators, because compliance with that before was very, very low. So cycle two, I did an education on the CABC indicators for transfer patient satisfaction and the transfer guidelines. Implemented a reminder system for the patient satisfaction surveys now that it was in place, and then made sure that the ISBAR tool, because initially it was just the transfer tools on one side of the paper, the ISBAR tools on another side of paper, but it's in one of the midwives' office. They have to go grab that paper to have the IS-Bar tool. So I actually put the IS-Bar tool laminated in the birthing rooms on the back side of the door with some other things that are there, so that in an emergency situation, they'll have it readily available. And then the midwives wanted a couple of things changed on the transfer tool itself, so those changes were made. Go through, which we're in right now. Initially, it was just they wanted me to focus on education with the midwives. There's 4 midwives total, and I've been focusing everything with them. Actually making sure that all times are documented and things like vital signs, because those are the things that we're really doing poorly on, is making sure that the time the physician was called, or the time that the patient actually left the birth center, or the time that the patient arrived at the hospital setting. Those things were not being documented. So I made a short PowerPoint on the CABC indicators of compliance for transfers and patient satisfaction for the RNs, and just showed them what the tool looks like, and just saying, you know, what the nurse's role is. You know, it's very easy for the nurse just to jot those times down, so that the midwives are normally the one calling and, you know, doing all of the interventions, but the nurse can actually be documenting it for us. And then, since no patients during 2017, prior to my sending out surveys, had patient satisfaction survey, I implemented, started sending out surveys for all the patients that started January 1st and delivered. And so everybody in 2017 that delivered will receive a patient satisfaction survey. And then, like I said, the IS-Bar tool is available to the RNs now. So it's in the room. They've been introduced to it. And I made some changes for RAMP-D to that IS-Bar tool. I actually added some of the information that's on the transfer tool, those times, so they know what times they need to document, so that when the nurse is in there, they have that transfer tool that the midwife can use. I mean, that IS-Bar tool the midwife can use to give a report, but we can also make sure all those important times are being documented. So these are my run charts. Let's see. It's not there. Somewhere. There. Okay, so this is RAMP-A. So it is for education, it's staff confidence and communication. And so that's gone up since we started this. And this is just a survey about how confident they feel in communicating whenever they're doing report and making transfers. And so since transfers are not something that's common, and actually we had one my very first week of the cycle, of the first ramp, and it happened before all of this education was done. It was like the first day of the cycle. And so it's been really, really slow since then. As far as births overall, we've only had 3 births in the past 3 cycles so far. So it's really slow. So we may not have another transfer. So I've been doing some scenarios with the midwives, and I'm hoping that the very last cycle, we can do some really, really big is too. I'm trying to talk them into, I work at a university, and we have a nice simulation area, and a really, really good, being that you do simulation, you may have heard of Victoria, but I'm hoping that we can bring the midwives over on their meeting day, because they normally don't see patients, and actually do a couple of simulations with Victoria, and do a couple of transfer simulations with her, instead of just doing the small scenarios in the birth center setting, because that's how this data. So whenever they do the simulations, there's an IS-Bar tool that I can score how well they did on actually giving a report. And I think they're doing really well. I think one of the areas is just, you know, they keep forgetting to what the situation is in the very beginning. You know, why is the patient being transferred? You know, is she failure progressed? They'll tell that kind of towards the end when they're giving actual report. And then patient satisfaction scores, so those have increased slightly since we began. And then the number of returns, so overall they had a very, very low return, typically around 15%. And with the last cycle, first cycle it was 50%, because we only had 2 sent out and 1 returned, and the other didn't. But within the last cycle, we actually had a 38% return, which is pretty significant considering it was 15 prior. And then ramp C is percentage of the ISBAR tool completed. So how much did they actually give of the report? And then the use of the tool during the transfer. Did they actually utilize the tool itself? And then D is documentation of CABC indicators of compliance. So how many of those indicators, so how many things did they miss or not miss? And then with completed transfer records. And so, like I said, those things are all being captured basically with the scenarios or the simulations. So this is kind of where I'm stuck, is on C and D, because I really just don't know how to ramp it up from here with C and D. I've asked, the midwives, and they're kind of like, they like the tools. They haven't been able to utilize them a whole lot other than the scenarios. So it's knowing where to go from here.
Any ideas for Amanda?
I just have a quick question. So your tools are available to the staff RNs, and yes. But they're just, then the midwife said that they're just not able to use them as often?
Well, I mean, they can't really use them right now because we don't have any transfers. I mean, we may have one transfer a month. We may not have any transfers a month. Some months we have 3 or 4. So it just, right now.
Right. It's a volume.
Other than utilizing simulation.
Yeah.
Yeah. Other than utilizing simulation, I can't, get them to use them right now because they don't need to use it.
So I think that if you got them to go to a simulation lab and do a simulation, a sort of a real high fidelity simulation, something as true to life as possible, I think that would actually ramp up all of your ramps. It would be kind of the next step all the way around, so that then they're using the transfer tool in a situation that feels really lifelike. They're using the ISBAR tool in a situation that feels really lifelike. And when I say as true to life as possible, I mean, they need to pick up the phone and call, and there's actually a person on the other end. Like, you have someone that they are calling to make this, to actually give this report. You can use the simulator, like I'd imagine you guys have a birth simulator, and you can use that, or you can even use live actors as the patient.
Yeah, we have Victoria, and our simulation is set up amazing. When we have a phone in there, the phone goes to the control room. We have a control room where, they can't see what's going on. I mean, that's what I was planning on doing. It's just getting them to come over there, because it's not their facility. It's, where I actually work and I teach as a professor. So it's, getting them to come over, and she's working with me, and I'm hoping that it's going to work out. So if I do that, I mean, I can make that, it'll be basically ramp A, C, and D, right?
Yes.
Okay. Well, good. Okay.
Can you do some type of motivation to get them to go over there? Is it a motivational thing?
I think I'm gonna have to. I think I'm gonna have to. It's I don't know. A lot of them are older midwives, and it's just, they're set in their ways. They have their meeting every Thursday, and they kind of sit around this table and do their thing, and it's a lot more of chatting, and not a lot of, they say it's very poorly focused. So when I was leading my meeting, we had to do like the parking lot, because it very easily got off subject, talking about different things, talking about clothing, those kind of things. So it's just getting them to go, and it's 5 minutes away from where they are.
I have found that food is a great motivator.
That's what I'm thinking. Just doing that.
Like maybe do a lunch for them. I mean, it would be, but you would probably get them, oh yeah, I'll go for lunch. Get a free lunch, do the simulation, feed them lunch, and they'll probably, like whenever I gave my people lunch, my very first kickoff meeting, and they're like, I'll do anything you want me to do. I mean, they were like, this is nice.
Yeah, so that's what I'm thinking.
Great motivator that I've seen.
Definitely. Good. Okay.
I can understand their concern. It's scary to go and expose yourself in that way, and to have someone watching you while you perform in an emergency. And the more often, I'm sure you've done some research on simulation at this point, the more often that you take yourself out of simulation, the more often that you break simulation to laugh about the thing that's not really realistic or whatever, the safer it feels for people.
Yeah.
So having this, you know, that conversation with them in the beginning about how that the whole, I don't know how much you've really looked into simulation, but the whole conversation about needing to stay in this and how important it is that it feels like real life. And some of that stuff might actually motivate them. Like, this really makes a difference and it will be like real life. And there's no one there judging you. Like,
yeah,
you know, we're not going to have any other faculty members there. There will not be any, you know, physicians from the university. This is not an assessment of your skills. It's not a public display. It is just for you.
Yeah, and that's what I do with my undergraduate and my graduate students already that I teach. So I think they'll feel comfortable once they get over there. I think it's just actually getting them there. So, yeah.
Great project.
All right. I guess I'm next, huh? So I'm Rebecca. I'm a midwife in southernmost Illinois, down at the pointy tip. As far away from Chicago as you can get. So I'm doing an SBIRT for depression screening and appropriate treatment. Let me pull up some stuff here. Let's look at my ramps here. Can you see? Can you see it?
Yes.
Okay, cool. All right. So for May A, it was staff education and engagement via an in-service and surveys till I got to 100% of all staff. And then for B, to start off with, we were tracking documentation of a readiness to change shared decision-making tool, which was just a readiness ruler, just very simple, on patients that screened positive for the PHQ-9. And then tracking documentation of handouts given regarding the support systems available for patients that screened positive. And then C was for the MA or the RN to screen all antepartum and postpartum patients at every visit, and track those increases biweekly. And then for D, we were tracking algorithm usage of the American Academy of Family Physicians. They have an algorithm for postpartum depression and treatments and whatnot. So let's see here. So for the second one, we were continuing staff education. We had some posters that we put out. And then we did a survey afterwards, and just in attempt of, you know, to get everybody up to 100%. And then we continued the tracking and usage of the readiness to change assessment. And we were, you know, just continuing with the shared decision-making engagement for B. And then C, we were continuing implementation and tracking of the NICE guidelines, which is where we got the screening at every single visit, with the PHQ-2, and then going forward to the PHQ-9 if we had someone who screened positive for the PHQ-2. And then continuing documentation of the algorithm usage by the CNMs. And we attempted to, you know, educate the physicians on the algorithm and provide copies. They were not interested at all. So that wasn't the greatest. So let's see. And then I'm going to pull this part up because I don't have it on my PDSA form yet for what we're doing this time around. So for A, we're continuing staff engagement and education through the creation of an award wall on the break room. And I'm just putting little tidbits up there daily just so they've got something new to look out. And then we've got a spot for just little stars for people who are, you know, doing a good job. And so that's their little achievement for continuing screening and patient education. And the big thing also this time around is educating and engaging the staff at our Heron, Illinois location. So this is a smaller clinic. I thought that would be a good place to go to next. I'm there one day a week, and then the rest of the time I'm at our Carbondale office. So we've got an FNP over there. She sees some OB and postpartum patients here and there. So we educated her and her LPN this week. And then continuing readiness to change assessments and spreading to the Heron, Illinois office for that, and engaging the patients who are ready for change to choices and support systems. And we spread that also. And then just continuing with screening and then tracking the algorithm usage by the CNMs and now by the FNP as well. So that's what we got going on. And then let's see here. Where's my, here we go. Pull this over here. So team engagement. This is what we've got going on right now. You know, it was kind of slow starting off, but really we've had really good engagement with our team. They've been really open to everything. So, that's been not a problem at all. Patient engagement. I don't know what's going on with my little exclamation point here, but, for patient engagement and using the tool, we're doing great. And even whenever we added on Heron, they were like, oh yeah, you know, we had it set up to where we already had our laminated readiness rulers like right there. And so it was an easy add-on. We haven't had any issues with anything going down really in that arena anyway. I've got one thing coming up here. I'll show you. So again, with Heron added, it really didn't bring anything down. Everything's been great. And again, the documentation of appropriate treatment, we have Athena. And so I shared our, all of the templates that we had made for appropriate treatment, and just an easy addition in our assessment and plan templates. We've got one that's for mental health. It's got everything on there. So it's been really easy for Amanda, our FNP, to just, you know, hop right on in. So there hasn't been any issues there. Team compliance, again, it's been just fine and dandy there. And then this is the completion of the readiness for change assessment. And again, I'm just at this point, I'm where I need to, you know, figure out what I need to do next. So this is, I had a question about what to do here. For the shared decision-making and the support options that we've got within our Shawnee healthcare family. We've got behavioral health that we can refer them to very easily. So as you can see here, I've got one that's empty. We didn't have anybody screen positively that day. I didn't know exactly what I needed to do with that one. Because I don't really have data for that day. So any thoughts? Everybody was happy that day.
It's not going to look great on your run chart, but I think you just explained that. You just explained that you didn't have any, you know, no one screened positive that day. Okay. What is your actual numerator denominator on this?
Here, let me look over here. For that day, we had let's see, 1, 2, 3, 4, 5, 6. There were only 6, and you know, so we didn't have any positive. So I need to.
So your numerator denominator on this was the number of patients that received the decision-making tool over the number of patients that screened positively?
Right. So yeah, we
Right.
didn't have anybody scream positively that day.
Okay, so this is one of those cases where it is both 0% and 100%, depending on how you want to look at it.
Right. Exactly.
I would just put in a 0 here, and you're going to have a spike that goes all the way down and comes straight back up, and you're going to
Okay.
put in an annotation box there that says no patients scream
Okay.
positively this day.
Okay, cool. Voila.
Done.
All right. So yeah, and I'll make an annotation there for that one. Okay. And then here's what I was talking about of this is showing when we got down to 33% here. We're doing great, you know, and then we've got a 33%. This is a day that I was at Heron, and we didn't have any reminder at our morning huddle that day. And so this happened. And so I've started on days that I'm not at Carbondale. We've got Athena, and I'm doing a big text to everyone, basically. As you can see, the next one was back up to 100, but it was just like this reminder. If I lay off on, you know, reminding everyone, it just went down in the trash can. Look at that. So yeah, we had a little talk with everyone, and we got back up to 100 for our Friday there. And again, this really wasn't from adding Heron. This is from Carbondale, because Heron was doing fine. So, and then algorithm usage, again, we've got those templates, and adding on Heron was no big deal. It went great. Team satisfaction, we've went down a little bit, and that was from Heron. So I'm just gonna maybe bring some more donuts next week, or bring coffee for everyone, something like that. And then here we go. This is our patient satisfaction. And again, we've got some, it's not going way down or anything, adding mental health screenings on every single one. And actually our last one, that 5 out of 6, are the one that screened less than, here, let me pull this down so you can see. Whoops. Less than excellent on advice and treatment. That was actually a patient who was having some psychosis going on, and she was very angry. So I don't even know if I should, seeing as she had some psychosis going on, do I keep her evaluation or not? I don't know.
Yes, I think you keep her evaluation, and if you want to, you can make an annotation box there that says,
Okay.
there was one patient very unhappy, whatever, that kind of thing.
Yeah.
And explain something about that,
Okay.
mentally unstable, or however you want to say it.
Right. She ended up going inpatient that day as well. So yeah. And then wait times. We have just started with Athena in the past several weeks. And so wait times overall were higher just because we have, started this new EHR, and so you can see them going down, and that is us, I think, becoming more familiar with what we're working with. So because there are times that I feel like waits are longer because I am in there, talking about, options for people who screen positively and everything. And I feel like I am in with patients more, but our wait times are going down. So I think that has a lot more to do with Athena than what we're really doing. So anyhow, so at this point, I am just trying to figure out what I want to do for next time around. I think probably I'm looking at some guidelines for adding annuals, adding gynae problem visits, and seeing where to go from here. Because where we're at is, I think we're in a good spot. So
that sounds great. Just adding those other visits, to just broaden the scope.
I had thought about adding that this time around, but I was like, oh, wait, I better go to Heron first. and get them set up before I went on to anything else. So that's, I think, our natural next step.
It is. Yeah, I think that sounds like a perfect way to ramp up. And it really ramps up all of your, it
Right.
takes all of your ramps to the next level all at one time. And it's a natural place for an annual exam is a wellness exam. So it is a
Right.
natural place for depression screening. It is probably something that all of us should be doing in those exams. So that's awesome.
Thanks.
I'm trying to remember, there was something I wanted to say about one of the run charts and I don't remember now. Mostly, I guess, I don't remember exactly what I had wanted to say before, but don't worry about those crazy spikes when things go way down or go way up or whatever. For one, the longer you track data, the less those look as funky as they look right now. But this is just what's always going to happen when we track data a couple times a week and we have, you know, relatively low numbers. There's no way around it.
And when volume isn't that great, just having 1 or 2 off, it's like yowza. So right.
Yeah, definitely. So how are you guys feeling about your projects at this point? Like, how do you feel? I'd like to really think just a little bit about how these projects might continue without you.
Well, I'm at my site. So this is something we'll make a thing. But for me, I'm like, I am already thinking of other things that I need to do these things on. And I know it's really nerdy of me, but like, oh, this is what's next.
Oh, I can't.
Everybody's rolling their eyes at me at the clinic. And they're like, Rebecca, stop.
This is what happens in the DMP. This is, I can't even tell you. This is what will happen to all of you, because once you have done this project and you know that you have a system and you know it works, you will never, ever look at problems the same way again. You are never going to go out into the world and see a problem and be like, whatever, I don't know what to do about that. From now on, you will always be like, oh, you know what would help that is a PDSA cycle.
Exactly.
It sounds ridiculous, but it is not. It's absolutely true. And you guys, you can't even know how much listening to all of you guys is so inspiring. I feel so sorry for my clinical practice, because almost every day I'm saying, you know, this would be a great project, or I have a student who does something like this, or every time we have a project or a problem at work, now someone asks me, do you have any students using a tool for this? So yeah, I think half of the amazing thing about this program is being exposed to one another and hearing of all the great projects and seeing all these things. So it will definitely be a skill to figure out how often do you track these numbers after the project, because you should continue tracking, right? I mean, right. We all know, you know, what did Mary Breckenridge tell us? Like, we should track anything that we want to do well in. So you should continue tracking, but you're probably not going to continue measuring twice a week. I would imagine that at some point you'll get tired of that. Also, can someone else be in charge of some of this? Is there a way to transition so that that you are not putting in your own effort to keep this going all the time, especially as you take on new projects? At some point, you only have enough time and attention to keep a certain number of balls in the air, and you don't want this one to drop. So are there other people in the clinic that might at some point be interested in helping track quality? Or maybe this one everyone believes in so much that if you do a quality, like if you do some chart checks, once or twice a month on this, maybe that will be enough.
We've had some staff changes with my group, and one of our medics actually took it upon himself to go through like my spiel at the end of the visit. And I was like, wow, okay, and he was just really comfortable, like going through, here is the MyPlate method, here's all the information, the website you can go to, the calorie deficit, that type of thing. So that's something that they may be able to implement, and that might be able to ramp up all of my ramps as well, using support staff to help with the education of handing out the tools as well at the end of the visit. It's a possibility.
Yeah, definitely. We just want to look towards sustainability because it's such a good habit to get into. It is such a good exercise to figure out how does this continue. And it will be an important part of your initial write-up or your final write-up at the end. You will write this down and say, this was a great project. you know, and it will not be any fun to write. This was a great project, but now as I'm writing this, it has completely died and there's no lasting effect. So that will not be the case for any of you guys, I'm confident.
I already have one of the midwives, because the patient satisfaction portion is the one I'm really worried about, you know, keeping up with, because it was not kept up at all initially. So I have one of the midwives who's supposed to take it over for me in June. And so she's already set in place. So hopefully it continues.
Awesome. Well, does anyone have any questions or anything else they want to talk through?
I think I'm good.
I think I am too. I think just talking about that helped a lot.
Good. And everyone feels confident. They know how they're going to ramp things up moving forward.
Yeah.
Finish strong.
Definitely.
All right. Well,
Flown by, hadn't it?
it has flown by. It definitely has. Yeah, and I have not been, you know, as much in the thick of it as you guys, but every time I read your projects, every time I get a new set of PDSAs, I'm truly blown away. Every time I read through them and go, wow, what? Oh my gosh, that's a great idea. And, you know, look how it's working. And just, you know, don't lose heart, don't lose energy at this point. Keep going. You're very close.
Thank you.
Thank you. I have a random question that doesn't have to do with our project. I don't know if I dreamt this or if I saw this somewhere. Are we supposed to get an A in PC 731?
Are you supposed to get an A?
Or passing or something? Did I dream this? I could have sworn we got an email saying you should be getting an A in PC 731.
I have not read anything like that, but that doesn't, I have not always read every single thing.
Do you gals know what I'm talking about? Like I said, it could have been a dream. I don't know, because I was like, wait a minute, did I dream that? Was that really an email?
Well, you know, it's interesting that you bring it up.
Do you remember seeing that?
No, I don't.
No?
It just,
Okay.
It's always been 80 is passing, right?
Well, that's what I
Right,
thought,
right.
but I was like, wait a minute, didn't I read somewhere they were like saying that we should be, you know, doing this? Okay, I
will
said
tell
that was
you-
just a random.
We have a little bit of a feeling about grades, and it's, I think, worth sharing for a minute. You know, as students, and mostly as people who wanted to go back to school again, you are all people who get a certain amount of validation from grades, right? And grades are really just supposed to be a measure of how well you're doing. But this is hard. It is really hard for us to use grades in that way and to say, yes, you're doing well, or no, you're not doing well. Ultimately, this class is, I mean, every teacher would say this. Every teacher would say this class is not about the grades, but I really mean it. If I could make this class pass fail, I would. The grades, in some respect, just sort of get in the way. When we take points off or something, we are only saying, hey, pay attention to this. And there's kind of a feeling that if we don't take points off, sometimes people say, oh, well, I mean, I got, or even if we do take points off, I got 4 out of 5 points for that section, so it can't be too bad. And just sort of keep doing it the same way. So the points off really are not terribly strategic in this course. The points off are just saying like, hey, I want you to pay attention to this a lot. I'm going to take a lot of points off so you notice. But the thing is that the project has to be right. You really almost have to get 100, you know, and if we had our way, that's what would happen. That you just keep working on the project until you get it exactly right and you know how to do this. It's a course where you really need complete mastery of something and not, you know, there's not really a way for me to say, like if you have a successful project where you have done all the things and you've ramped it up each time and you have made an actual change in the healthcare environment, that is 100. That's a win. That it's not an 85 or a 92 or an anything.
That makes sense.
And I think sometimes I get these emails where people say, oh my gosh, I'm so sorry. Like, what did I do wrong? I made a 92. And I feel like, well, I don't, you know, nothing. That actually wasn't what it was about for me at all. I had those comments and I really need to make sure you pay attention to them. I probably didn't even calculate the percentage. So All right. Well, this has been fun. I feel like you guys are, we're ending awfully early, and so I don't want to shortchange you. If you have anything else you want to talk about, we have time. We can talk about things. But I think just having 3 students cuts down, by 50% or so on the amount of things we have to say. So
Yeah, it's all good.
good. Well, I'm impressed by all of your projects. I definitely got lucky on this session. This was fun, and there's not anything I'm worried about with the 3 of you. So,
Very good. Thank you.
Thank you very much.
all right. If you have questions, if there's anything you're worried about, contact your continuity faculty. We still want to talk these things through, if there's anything that comes up along the way.
Thank you.
Awesome. Thanks.
Thanks. Have a great day.
All right. You guys have a
Have a good
great
one.
Saturday.
You too.
Bye-bye.